Welcome, good afternoon, and on behalf of the Association for Vascular Access and the I've Saved That Line webinar series, I welcome you to our presentation today. 18 months of sticking to it, dedicated site care using gum mastic adhesive for vascular access dressing adherence. I'm Blake Hotchkiss in the AVA Education Department, joined with me today by Judy Thompson, Director of Education at the Association for Vascular Access. AVA is dedicated to providing you with informative content from experts in the industry of vascular access. Today's webinar is brought to you by Eliquest Healthcare Incorporated. Let me introduce our speaker. So this is Elena Nelson Squires. She's a vascular access team coordinator for Northern Colorado Banner Health. She holds her board certification in oncology nursing practice as well as her VABC. As a leader and vascular access specialist, she shares her expertise as a clinical nurse educator and placement specialist for BD Bard and a consultant and speaker for Eliquest Healthcare Incorporated. Elena lives in Colorado with her fiance, Todd, and their 4 dogs. Her daughter lives close by as well and is also a nurse and ICU manager. To highlight her creative outlets, Elena has a passion for gardening and getting some dirt therapy. She often imagines herself as the old hippie chick peddling her refurbished things, especially spice racks and costume jewelry. What an amazing retirement plan, in my opinion.
Thank you.
And without further ado, I'm going to hand the stage over to Elena.
Good afternoon, and thanks for tuning in, or morning or evening, depending on where you are. I'm going to get right to 18 months of sticking to it. Our team took over site care, and we use gum mastic adhesive for vascular access dressing adherence. Again, I'm Elena, and these are my disclosures. I am a vascular access team specialist and team coordinator for NOCO Banner Health. I work per diem as a clinical educator for BD Bard and consultant speak for Eliquest. What I'd like you to be able to do today is explain things as you need to with relationship between dressing integrity and risk of CLABSI. I'd like you to be able to review clinical outcomes that we've achieved using gum mastic adhesive with our central line dressings. And I'd really like you to be able to speak to the financial impact of adding gum mastic adhesive as you move forward and you consider using this product. I think it is important to be able to speak to all avenues of interest to everyone in your institution. We know that CLABSI is a 0 event tolerance, and there's a good reason for that. When we were looking at ways that we could impact CLABSI beyond insertion, I looked at the last CLABSIs over a year period of time a few years ago that we had. There were 8 of them, and indeed 2 of our patients at our larger Northern Colorado facility did not survive their CLABSI. So that is right in line with what the literature says. And of course, current healthcare crisis accepted, Medicare, Medicaid are not reimbursing for nosocomial CLABSIs, and that estimate that I have there for you on the screen of $45,000 is from reading several different sources to come up with some sort of what I felt was an average CLABSI expense that is often the entire burden of the institution where nosocomial infection occurred. So we're at polling questions now. Blake?
When is the risk of CVAD exposure to microorganisms the highest? So go ahead and select. What do you think? When the patient is immunocompromised with site disturbance or catheter entry, or when the patient is receiving care in the home? And 86% of people said with site disturbance or catheter entry.
And it kind of has to do with mnemonics. So, and honestly, immunocompromised patients and patients in the home care may have increased risk factors, but truly you are going to have problems when something enters or disturbs the site. So if it was a trick question, y'all didn't fall for it. So, vulnerability, when is site disturbance? Well, of course, with insertion, we're disturbing the site, we're creating the site. Catheter use, and if the dressing is disrupted, unintentionally especially, but also even during our dressing changes where we intentionally remove the dressing. The first thing that I wanted to talk about briefly is insertion. There's been a lot of progress made on insertion. A lot of folks use checklists and validated observers. Almost everybody, if not everybody, uses maximal sterile barrier. And in fact, 2007 was the last year that we saw a CLABSI at any of our facilities in any of our vascular access team placed line that was even within 2 weeks of insertion. So the other point that I did that I have heard spoken about is the percent of time that insertion accounts for, and very conservatively, 1% of the time is the insertion in the entire life of the CVAD, and that is allowing 2 hours for insertion, and there's usually just an hour or less involved. And based on a 7-day dwell, which our middle facility, McKee Medical Center, has, at NCMC, our larger facility, most of our CVADs are in 9 to 10 days. We have a really good program also for avoiding placement of CVADs unless absolutely necessary. So truly, it's probably closer to 0.05%. So we've done a lot of work on this very short period of time. Then there's entering the catheter. So that's using the line. That's anything that disrupts that interluminal space. And we have policies about that, but there's a lot of opportunities to go off policy or to have an error in this area, changing the needleless adapter, flushing the catheter, giving medications, the amount of time you scrub or don't scrub. So there's some opportunity there potentially. And of course, with dressing integrity, because once that hole is in the skin and the catheter goes through it and into the vein, we have a slip and slide for microorganisms to get into the vein unless we put something over it. And again, we have policies around that. We say we want to keep a antimicrobial disc and a transparent membrane over our site for 7 days intact, and to change it if it is disrupted earlier. And that brings me to polling question number 2, Blake.
So considering your current practice, where do you feel a change in practice would have the biggest impact in reducing CLABSI rates? And let's see here, insertion was 3%, catheter entry 27%, and site care and dressing practices made up the most, 70%.
And that's probably in line with what we were thinking. I kind of prefaced what we've done for insertion and what's happened with insertion at our institutions. And we looked a little more specifically for Northern Colorado, and I definitely encourage anyone out there to look specifically for their area. And this is kind of what I came up with. Catheter entry. The vascular access team members, even though there are quite a few of us now compared to what there used to be, cannot possibly observe or actually perform every entry into that catheter. We can indirectly affect this possibly by partnering with education, teaching classes ourselves, and doing one-to-one teaching that we do, and we will continue to do that, but it is still an indirect effect. However, when we think about dressings, it is possible that we have enough coverage. We now have 24-hour coverage, and we've done some things with coverage for us to take over routine site care. So in the past, when we were first thinking about doing something to improve our CLABSI numbers, we knew we could probably do this with some creative staffing that we subsequently accomplished. But can we improve outcomes? So now we want to know a little more about dressing disruption. So when a dressing comes off prematurely, is this a cause of CLABSI? Well, there's been a multi-center randomized study that says, yes, there are some pretty big increasing issues the more disruptions you have, and even site colonization issues, the more disruptions you have. So not only do we hypothesize it, but there is a study, a review study showing us that this happens. So next we have to say, all right, if the dressing comes off prematurely, it's a problem. How do we fix that? So went back to the literature and looked for something we could use to help us fix this. And this was all probably going on when we first started around second quarter 2018, and we found a couple of current articles, studies that gave us our direction. One was from Shelley DeVries, who was able to keep 93% of her dressings on with her team using a gum mastic adhesive. And so my next question is, what does that do to my site disinfectant? And the same year, we had a study from Ryder and Dully showing us that skin disinfectant is not affected when gum mastic adhesive is applied over it. And then probably the thing that helped this happen for us is that we did have access already to medical grade sterile gum mastic adhesive. I had to special order it, but it was in place in our organization, which was helpful, which made things quicker for us. So now we have a question, right? Are we going to be able to do this? Can we reproduce results? And does it do anything to our CLABC? So the nuts and bolts of what we did is we ordered a box of gum mastic adhesive. There were 48 ampules in this particular box. So we found 33 patients that we could dedicate all of their site care, from insertion to time to go home and line removal or sending them out the door with their line, that we could use gum mastic adhesive on throughout their stay. And that is what we did. And then at the same time, there were other patients in the hospital that had standard CVAD site care. And I performed a 20 chart review of those patients to have a control population, and then we compared. We did not have any dressing disruptions, even partial, among our 33 patients. And I guess I should explain what we were considering partial was a dressing that lifted enough. We have a gauze border on our dressing, and it would have been a dressing that lifted enough beyond just the very edge, just a tiny little bit of the edge curling up. Anything that lifted into the gauze border was considered partial, and anything that even pigeonholed down to the site is considered complete for us. Now, in those 20 control patients, and this is what was documented in the chart, and we have found in the past that not all early dressings get charted unless we're the ones doing them. 7 of those patients lost their dressing. That was 35% of this group. So we had 0 versus 35%. It is important to note that neither patient in either group developed a CLABC, and that probably had a lot to do with the fact that this particular institution, we have a fairly large institution in Northern Colorado, and then a couple of fairly small ones. One's really tiny and the other's just small. And we did it at our middle facility, or McKee, and they hadn't had a CLABC problem in a long time. So now we're looking at, hey, everything sticking is way better than a third of them coming off, but we didn't have any CLABC, so there's no way to answer that question. So I'm trying to decide, do I do a larger trial? Do I bring it over to the big facility and do a larger trial? Do we just implement, or do we just forget about gum mastic adhesive and continue what we were doing because nobody had a CLABC? And at that point, the manager part of me kicked in and said, what other things do I want to know to continue this trial? And I think this brings us to the next polling question. Yes, Blake, if you would, please, sir.
So beyond improving patient outcomes, what else is of most value to the healthcare industry? So the results here, reducing supply costs made the most, 51%, followed by recovering nursing time, 39%, and reducing labor costs, 11%.
So this question was kind of asked just because I was interested. I actually looked at all 3 of these things because I thought they were all 3 important and all things that I could speak to my supervisor and say, hey, here's what we're achieving, we're going to do this thing, or here's what we're not achieving, we're going to let this go. First, I looked at supply cost, and a fortunate thing of choosing McKee Medical Center is the average inpatient CVAD dwell there is 7 days. So if you needed an additional dressing change, it was likely an additional dressing, so additional supplies. So based on that, 7 supply kits cost us about $9 each, that's $63. Had we placed gum mastic adhesive under the dressings for all 20 of those control patients, and this is all 20, not just the 7 that disrupted, it would have cost about $27. So up to 67% of supply costs for this particular small procedure, dressing changes, but important procedure that we do at the facility, are potentially recuperable. So then the other thing I said, well, okay, we got really lucky and we didn't have to early change any of our 33 patients' dressings, but that probably will not happen if we do a bigger trial. So where am I going to break even at on supply costs? And that was around if 4 of those 7 dressings had still disrupted and had to have an early dressing change with gum mastic, we would have broke even as to using it versus not using it and have 7 disrupt, if that makes sense. So then, because I was doing a presentation on this, I went with some national statistics, and the average cost to staff a registered nurse per hour over across the nation in 2018 was $55.27, and I'm sure that includes benefits, etc. So a dressing change, if you do everything correctly, you've got to get your supplies, you've got to wash your hands, you've got to prepare the patients, etc. I think 15 minutes is a very reasonable amount of time to allow for this, considering all components through documentation. So that's about $14, a fourth of that 55. Gum mastic adhesive application takes about a minute to do. It's going to add a minute to the procedure, so there's another buck. Doing the math, this meant 7 dressings cost in nursing labor dollars about $100, and it would have been close to about 20 to use gum mastic adhesive, again, on all 20 of those control patients, or even 49 for all 53 patients, because we did use it on those 33 patients. So looking at that per dressing, using it on all comers, you still half the cost in nursing labor, 49 versus 97 roughly. With, I don't know why I said time is a little more complicated to quantify. It is math. So 240 hours is 4 hours of site care for 20 patients. You get an extra hour and 45 minutes or 105 minutes when you do those 7 extra dressings. So you get 345 minutes. You've increased your procedure using gum mastic adhesive by a minute for all patients. So instead of 240 minutes to do those original 20 dressings, you have 260. And so looking at the difference percentage-wise on time between 345 minutes with those extra dressings and 260 for all those dressings to go on and adhere the whole time, we could save as high as 25% of time. So anytime you can tell a nurse, here's 25% of your time back, even on one little thing, I think they will find something very clinical and very appropriate to do with that time. A simpler way of looking at it, and what I put on the graph next time, is every time each patient that had to have twice as many dressings as they should have had, which was the case for all 7 of those patients, nursing time was doubled doing that particular task. And then just because we all like them, put it on the bar graph so that we could really see it before and with the product. So that kind of helped me make the decision as to what to do. We went ahead and fully implemented, but before I get to that, I'm getting a little ahead of myself, I apologize. Did we reproduce improved dressing adherence? Oh, yes, we did. Was it through use of gum mastic adhesives in particular? Yes, it was. And we still don't know about reducing the risk or the incidence of CLABSI from this early trial, but we didn't disprove that hypothesis either. So we moved forward, and on January 1st of 2019, McKee Medical Center and Banner Fort Collins Medical Center, our two smaller facilities, we began doing site care and daily rounds. We began doing site care at North Colorado Medical Center, the larger facility, in February because I had to do some creative staffing to get that accomplished there, where we had a lot more lines. We round on every patient, and ones that are disrupted or ones that are due, we change the dressing and we apply gum mastic adhesive most of the time to most patients. There's obviously a couple of variables here because we now have experts doing lines. And the other thing we do is an audit of other metrics that have to do more with lumen entry, and I will get to that later on. And of course, I have been working with infection prevention for years. We drill down on every CLABSI we have, and that process continues. So here we are today in May of 2020. Is gum mastic adhesive still holding, still keeping our dressings from disrupting compared to not using it? Yes. However, there has been this little thing called the coronavirus that has come along and changed healthcare temporarily as we know it, and it actually did impact what we do at the bedside a little bit. Prior to the current healthcare crisis, we were daily rounding on every single patient that had a central line. We did see a few disruptions, so we did not maintain that zero, which I anticipated. Most of our disruptions are partial, and most of our disruptions are actually with new provider placed lines, and they do not yet have access to the gum mastic adhesive. We are still having to special order that. And most of those partial disruptions are occurring on high neck IJ placements. Now, if a line is bleeding, and we do occasionally see oozing from lines, it's usually with our very, very large bore HD catheters. Even if there's gum mastic adhesive on the site, there's usually at least partial disruption before we can get there and do what we do to control the bleeding. However, the most important thing, the thing to take away is our CLABSI rate plummeted from 5 in a year period of time down to 1 at our large facility with the use of gum mastic adhesive. Since early April, we have not been doing rounding on COVID-19 patients. This was due to a lot of panic and fear, to be quite honest, by our ICU staff, and they asked that we not use their PPE just to go in the room and look at the line and come back out. Our physicians said, we don't want any CLABSI, so we still want you doing site care. So we do go in when site care is due, and actually physically be in the room and do the site care. However, there has been, fear does weird things to people, and many of our critical care nurses will preemptively change the patient's dressing instead of calling us. They don't want us going in there and using their PPE for that. Plus, I also honestly think there's been a lot of confusion between us not rounding but us still doing site care versus maybe we're not doing anything, and they want to be good stewards to their patients. So what I decided to do to see, okay, here's another chance, another opportunity for me to see what gum mastic adhesive is doing. So on May 4th, I audited our charts. We have a pretty easy way to find out who all has central lines in our facilities. And at NCMC, we had 30 inpatients that had central lines of some kind. 47 lines had been in these patients at one time or another. 13 on May 4th had already been discontinued, and these 30 patients, between them, had 34 active lines. The 4 extra lines were HD catheters in addition to central venous access for other purposes. Those total days were 419. And they represented 86 dressings. And weirdly enough, 43 were performed by our team and 43 dressings were placed either by the bedside nurse or possibly by a provider at insertion, although usually at insertion what happens is they stitch down their line. Yes, they still stitch down their line and walk away and the nurse dresses it. But gum mastic adhesive, again, unfortunately, is not available to other staff at this point. 27 dressings out of this group came due early. So then I went back and I looked at who applied these dressings in the first place, the ones that came due early and had to be changed due to disruption. 4 of the 43 dressings placed with gum mastic adhesive, or 9.3%, 10 per 1,000 catheter days, if you will, had to be redressed sooner than the 7 days because of disruption. However, 23 of the other dressings had to be changed early out of 43. That's 53.5%, or 55 per 1,000 catheter days. Now, 8 of these dressings I almost consider outliers. There was persistent bleeding at these sites. Part of the problem is, whether to count them or not, is we were not called for this bleeding and we're supposed to be called for this bleeding. They were both HD catheters. Usually when we have a persistent bleed, it is in an HD catheter. And the bedside nurse changed those dressings 4 times each on those 2 CVAD sites. So if I take those out, we still have 42%, which is still way more than 9.3%. So on the next slide, I'm just going to show you the graph. So I did all the math again, and I put it on the graph again. So it's that same nursing time, nursing dollars, supply expense, and dressing lots. Please note that because the scale on the left-hand side is so large due to expressing the dollars and the minutes and the amount of minutes, I had to have a 1,200 total. I did multiply the dressing loss by 10 just so you could read it. So it's really 53.5% and 9.3%, but I wanted it to be very visible, the difference between the two on the graph. But this is that same graph, and as you can see, without gum mastic adhesive, everything is increased. And please keep in mind, just as before, I included the increased expense of buying gum mastic adhesive and that additional minute of time for the dressing care with gum mastic adhesive, and we still have savings across the board. So here's the big question. I'm one of 2 questions I'm interested in knowing what you think about, Blake.
So what do you think happened with our CLABSI rates before and after the COVID-19 crisis? And we'll say it's, well, I'm not going to say completely split down the middle because there's 3 questions, but so it looks like the most people thought it was down prior to, so with all the hard work you did, and then back up during the COVID pandemic. And then the no change was the second highest, and down and still down with COVID, 24%.
So it's on the bottom on this next slide, but the title is CLABSI is the lowest it's ever been. And I put whisper because you know how we don't say the Q word, we don't say the CLABSI associated with no or 0 loudly, but in 2020, this entire year, we have had no CLABSIs, including our COVID patients. So the ones above that I talk about are what we had, what we saw in 2019. So I don't know for sure if NICU patients count for CMMS. I do know none of the others count for CMMS when we're being, when our reimbursement is being held, are not given when we have a CLABSI. But I still wanted you to know this is what we've seen. It doesn't, just because it doesn't count against us for reimbursement or value-based purchasing doesn't mean it doesn't count for the person who develops CLABSI. So that first CLABSI was really frustrating to all of us. This is a very, very non-compliant patient. You can read what all happened. The good news was our team, this was actually at McKee Medical Center, so all those years of no CLABSI were lost with this CLABSI that occurred. I don't think there's a whole lot of things we could have done to prevent that. We did have very good documentation because we saw him every day and tried to convince him to let us do what we needed to do for him, and he just would not permit it. The one CLABSI in here, the second one happened, I think, around August, and just there was no obvious reason that the CLABSI occurred. So it happened. It just happened. And then the third one was on an umbilical catheter on a neonate. We actually, the NICU staff does their site care, and we don't use gum mastic adhesive on them. Most of you probably know that care for neonates is very different. And so, but we did, that was a CLABSI that we had, so I put it on here. So at this point, we're approaching, if you look time period to time period, 90% at our largest facilities. Keep in mind that our small facilities really don't have CLABSI, and so I put nearly on there because the non-compliant patient situation did occur. So what do we have to do now? We need to find new ways to approach these non-compliant patients. Ultimately, what happened with this guy is he wouldn't comply with anything, and he ended up leaving the hospital early because he wouldn't let anyone do anything for him. But it would be nice to, at the minimum for our team, find a way to get that site care performed or get the line out, and at best for the patient themselves, get them to understand that compliance is going to make their outcomes the very best they can be. We did revise the neonatal skin-to-skin practice. They do feel like, looking at the drill down on that case, that was the chance for contamination of that umbilical cord catheter. So that has been revised at our institution, and there's a barrier between that catheter and the patients when they do skin-to-skin. And of course, here very, very soon, we want to resume our rounds on all patients. Our COVID census has dramatically decreased, so I do see that happening by June for sure, that we can round on everyone, including patients that we need to put PPE on for. So this, now I am kind of interested in what you think here, because you guys are experts. Why didn't we get a CLABSI in those 23 lines that disrupted like they did? The bleeding lines, was it pure dumb luck? That we just didn't monitor for them? Or was it the influence of the team? Oh, I'm sorry, Blake, you were supposed to do that. I apologize.
You led right into it. It was perfect.
This is the one that I'm just curious, because I really don't know the answer to this.
Yeah,
I know it's not.
So yeah, the three questions for you guys, again, just pure dumb luck, insufficient monitoring, or influence of the vascular access team daily rounding and site care. And 67% influence of the vascular access team, daily rounding and site care, followed by,
Go ahead, I'm sorry.
No. Insufficient monitoring for CLABSI, and then the pure dumb luck was the lowest at 11%. So.
Okay, well, one thing I can tell you before I go on to the next slide is that it was not insufficient monitoring. Our infection preventionists did not drop their diligence in searching for CLABSI. So that I know it wasn't. They are very diligent. They even help us look for peripheral line-associated bloodstream infections. So I feel that the odds of it being that are extremely low. But I agree with the 67%, even though there's no sure way to know. We exemplified site care for over a year pre the crisis. We're reviewing those other factors that I'm going to talk about very soon, and we are giving them one-to-one, just-in-time nursing education when we catch something in the room that perhaps they didn't know they needed to do, or that they just forgot to do, or it didn't happen because of shift change, whatever reason. It is harder to let things slide when you're used to being watched. So I think if time went on, the influence that we've had would wane, but I do think that it is the influence we've had. And I think part of what leans me towards that is the fact that there was never overdue site care for any of these patients. So we either got in there and did it when it was due, or the nurse preempted us and did it when it disrupted or when it was due. before we could get in there. So here's that variable that I mentioned that I think is like super important, and that is what we do when we round. And every day we round on every central line patient, COVID patients accepted for a little bit longer. And we look for factors other than just the dressing. We look for the caps and the tips being where they're supposed to be, when they're supposed to be there. We check the date labels, and if it's not there or the date is expired, we bring that to the nurse's attention, and then we check that the CBAD lumens are clamped when they're not in use. And again, anything that is not correct, we either correct and then tell the nurse we did it, or we notify the bedside nurse to go ahead and get in there and get that done as soon as they possibly can. And we also send these elements in for formal auditing to our QI department. There's actually a form that we complete. I have that form on the next page. So if you guys want to take it and build something out of it and not reinvent the wheel or use it, you totally can. We don't do a paper audit on every patient because we do quite a few site rounds every day. We have a population anywhere from at a low 20 central line patients in our facility to way up in the 60s with the COVID-19 crisis. So we only fill out the form when we actually perform a dressing change, whether it's a due or it's an early dressing change. The other thing I need to tell you now before I forget is we have not been doing those paper audits since early April, and that's because we were designated as the line team at that point for our COVID patients. We upstaffed, and I felt like we needed to focus. We could still do the audits unofficially, tell the nurses when there's a problem, but we needed to be available for lines when they were needed to back up our doctors, our providers, and our patients. There's our form. It's pretty simple. We turn it in. I will tell you, it has patient RN on there. I often leave that part blank, but I think it is good that we have the when, the unit, and the person doing the rounding, especially, or the room number, and then they can tie it back to the unit. Like I said, you can use this document if you want. I had to put bars over brand names because a lot of us know our caps by their brand names, for example. But I think it's pretty understandable even with those things covered. And about 2.5 weeks ago, I got back some bar graft results. It was a little early to talk about it today, but what I'm seeing in general is we know from our rounds that people are not writing the dates on dressings when a provider puts a line in, whether it's the provider that puts the dressing on and doesn't do it or the bedside nurse that doesn't do it. So we know that's happening. Dated dressings, if it's a new site, it's probably not dated unless we did it. Overall, with the exception of ICU, all those elements that I talked about monitoring for have improved in all of our areas. This is comparing 2019, June, December to January, early April, when we stopped doing the paper audits 2020. For some reason, ICU slipped in that first quarter of 2020. I don't know why, but they actually did a really good job to begin with. I was actually impressed by, and again, I'm talking about our large facility at this point. By how well they did when we started doing these paper audits, and for something happened and things kind of slipped there. But everybody else has actually improved quite a bit. We have only been we have been using gum mastic adhesive since before June of last year. So we haven't seen a whole lot of change in the likelihood of whether the dressing is intact or not. Now, unit to unit specific, that's a little different, but when you clump them all together, there's not a really statistically significant difference. That probably means that dressings that disrupt, whether there's gum mastic adhesive present or not, disrupt about the same amount of the time, all the time, which is probably not that terribly surprising when you're looking at all comers. I did put an example of a line graph that I did with one of our units, our step down unit, on this page, just so you could kind of see how I laid it out in case it would be something interesting to you. And you can see that the orange bar for 2020 is above the blue bar. for 2019. And when I originally did this audit, in the Excel spreadsheet that QI sent me, they came up with blue and orange. And I was like, oh, good, it's Colorado, it's Bronco colors. And when I transferred it to this PowerPoint, it changed colors. So I totally had to change it back because all of the Bronco fans just would not have it any other way. And as my boyfriend says, what do you care? You're not really a football watcher. So maybe I should have made it the colors of the Colorado Rockies, because I'm a baseball fan myself. So one other thing that I want to touch on is we have used a lot of gum mastic adhesive. So what happens with it? And the first thing people think of is medical adhesive related skin injury, or MARSI. We have seen very little of that. So let me tell you what I think about when or when not to use it. When skin is very thin, we tend to use an alcohol pad or adhesive remover to lift the dressing, with or without gum mastic adhesive. So that helps a lot. We take our time. We don't rush ourselves through dressing changes. So we take the time to attend to the skin. If there is a lot of very superficial edema under thin skin, I tend not to put on gum mastic adhesive. It's almost impossible to keep that skin intact sometimes, even with a dressing that doesn't stick well. So we have seen skin tears in those type of situations, and we did have a skin tear on a patient when we were taking off the securement device, but typically we don't put gum mastic adhesive under the securement device. On occasions when I think it needs extra stickiness, I do, but our securement device is already very, very, very sticky, so most of us don't put the gum mastic adhesive under there, just where the borders of the dressing are going to go. We've seen some irritation when you're taking off the dressing, no matter how careful you are. There's been a couple patients I saw a bunch of little red bumps come up, and on those two patients, I decided not to reapply gum mastic adhesive in case it was some sort of weird allergic reaction that only occurred when I took the dressing off. And so I just chose, it wasn't that generalized erythema that you usually see when you pull a dressing off maybe too fast or on super sensitive skin. There was little red bumps, but I didn't see them when I walked up to the patient and I looked at the dressing before I started taking it off. So I don't know if that was just a reaction to something sticky being pulled off the skin, probably. Let's see. We have had, I talked to Seth, my team member who got this whole study going in the first place. I talked to everybody before I came here because I wanted to make sure I wasn't missing anything. And he says that when we have a dressing on a patient who then subsequently becomes very edematous in a short period of time, the gum mastic adhesive holds the dressing to that skin, and sometimes you have tension between the edge of the dressing and the skin that is not covered outside of the dressing, and trying to get that dressing off, he's had a few small skin tears. So based on that, if we're expecting a very sudden onset generalized edema, we may choose to leave gum mastic adhesive out from underneath the dressing until that edema kind of plateaus. And so my example for that is we do have a burn center at our large facility, so our burn patients. If we see that there's been some swelling that was unpredictable happen, we will take that dressing off. If it looks like it's straining the skin, and replace it just to let the skin sort of do what it needs to do to stretch out and accommodate that edema. Haven't seen any allergies other than that weird bumpy thing, which I don't know if it was an allergy a couple of times. I know that that's possible, and I've heard of them, but we haven't seen any at our 3 facilities. There are some people that don't like the odor of gum mastic adhesive. Some patients don't care for it. Most patients actually find it pleasant or just ignore it. And it does seem like once the gum mastic adhesive dries and we put the dressing on, the ones that kind of grimace or kind of go make little funny, I don't like that smell noises, are fine after that. And nobody has said, oh, don't put that stuff on because of the odor or anything else. Again, we don't put gum mastic adhesive below our sutureless securement device very often because it is a very sticky one. So only if I think I need extra stickiness do I put gum mastic under there. and we don't put it underneath where the antimicrobial disc goes. You basically use it on the outer edge where the outer edge of the dressing goes, and kind of have that little window where the, and I'm talking with my hands and you can't see them, where the the antimicrobial patch and the securement device goes. We don't typically paint the gum mastic adhesive on there. So it never ends, right? So I included our next steps here. I don't know how important they are to you, but we do need to get gum mastic adhesive in our central line dressing change kit, or at least get it available to our providers so that it's put on every single time, whether it's us placing the line and applying the dressing or someone else. I think it has proven itself. I think our outcomes show that. So that is something that I'm trying to time with when the components of our dressing change kits are allowed to change. We are a very large organization, and sometimes the wheels of that organization grind very slowly. We're going to present our audit findings at Nursing Leadership Council. We're going to talk about the value of the vascular access team, placing the dressings, using gum mastic adhesive. We're going to celebrate those outcomes that I'm seeing prematurely with the audits across the hospital in our general inpatient units, where they're keeping their patients' points of catheter entry safer by using their caps and tips and not hanging and attaching expired tubing. We'll talk about opportunities in our ICU from the little bit of drop that we've seen this year. And I really want to talk to our General Nursing Leadership Council regarding the 8 dressings for those 2 patients that were oozing, because honestly, I do not feel those dressings would have become that wet. I think if they had consulted us, which is something that they it is something we ask them to do when they have complications, to consult us, whether we put in the line or not. We have hemostatic powder, we'll use pressure, we'll use hemostatic gauze, all kinds of things to seal the site. And actually, I've had a couple of instances in the last little over a year where I've had to refer my patient back to the provider because I suspect they had a venous tear with HD catheters going in, and we just could not get the bleeding to stop. But we pick up on that a lot quicker than the general nurse does. And I think I might be about there. Yes, those are my references. I think they're referred to on each slide, but I put them all here together for you as well. And then these are my teammates. The original group of us is in the corner because we would not be where we are without them. And we would not be where we are and where we're going without this large group of people to the right there. And I appreciate them as much as I appreciate all of you. I appreciate your attention. I thank you for everything you do for patients. If I can help you in some way, there's my email address there at Banner Health. You're very welcome to email me. I speak a lot on the Vascular Access Specialist Infusion forum on Facebook, so you could get a hold of me that way too. And if you have any questions, I think we're there.
Great job, Elena. Thank you so much. So we do have questions. So let's start with the very first one we got. Is there an age restriction for using gum mastic?
You know, I am not sure off the top of my head what it is that we would do. That is a good question. We do not use it on our neonates. We have not placed a central line in a child for a long time. So I would probably refer back to the vendor for that answer, honestly, or a vendor for that answer.
I did want to mention that we have finished the CE portion of today's talk. We're in the Q&A portion if any of you need to leave right now. So if the CE portion being over, if Elena happens to say the name of a product, if I happen to, this is where the conflict of interest hopefully will close itself. So just to clarify. Now, does gum mastic replace a traditional dressing?
No, it is liquid in an ampule. And what you do is your site care as you would normally do it. Of course, when we're setting up, because it is not part of our central line kit, we'll tear open our ampule package and drop it in there so we can do a sterile dressing change. And you squeeze the ampule, much like you squeeze chlorhexidine to clean with, after you've scrubbed and after you've let your site fully dry, and then you just paint it on. And so if you have I think it's a 6x9 square that we usually, some sort of transparent membrane dressing that we put on our sites, most of us, it's probably the inch border around there where you're going to put that dressing down. And then you want to let the gum mastic adhesive dry too, which is a pretty quick process.
Do you also use a skin prep?
I personally do not. Sometimes some members of my team choose to use a skin prep. Some people who I know also use gum mastic use a skin prep too. I don't think there's a contraindication to it, but I personally do not. I allow my chlorhexidine to fully dry, and then I use my gum mastic adhesive and let it dry, and then I put my transparent membrane dressing on. Which I probably did say that brand name during the presentation. So
we all slip up on occasion. So yeah, as long as you don't say it over and over and over, I think we're okay. Do you use glue, tissue adhesive?
We do not use glue. We're interested in glue. Unfortunately, so the fortunate thing with gum mastic adhesive is it was in our system. Glue is not in our system, and we got a hard stop on that one when Seth is the one in the upper left-hand corner. He very much is responsible for this trial and the impact that we have had. It was his interest in pursuing this that got this whole thing started. He also was interested in pursuing glue, and he got a door shut, unfortunately.
I hate those doors.
I hate those doors.
I hate those doors.
So imagine you're applying the gum mastic adhesive to the skin and not the dressing. I guess one of the questions here is, does it help with catheter migration, or did you see that in your study?
Because we use that sutureless securement device, it doesn't really have an impact on catheter migration because we used it before and after. I don't think it does. I will tell you that I had to leave, however, I know where that question is coming from because I had that same thought myself, and I had a line I was placing. It was a PICC line, and for some reason I had measured just off enough where I had more out than I was comfortable with, and of course I'd removed the introducers so I couldn't consider taking it out and trimming it a little more. And I laid that gum mastic adhesive down where that catheter was going to sit on the skin because I had room in between the securement device and the the antimicrobial patch to do that. And I did notice when I did that dressing change that it was still stuck there really well. So I think it has the potential to help if you have a lot of external catheter, but I can't say for sure.
Yeah, I know that there are a lot of dressings, like a lot of people are marketing dressings with built-in securement features. So like, I want to say those patients who need like ultrasound guided peripheral IVs, and they have got the ones with the shirt and the shorts, or however the rep likes to describe the dressing application. But you know, might help in those more than some that have, you know, like your engineered stabilization device or sutureless securement device. Yeah.
So we have a couple questions regarding Marcy that you mentioned before in your presentation.
Okay.
Pushback from wound care on using this product because of Marcy. What would you say to a vigilant WOCN that is not in favor?
Well, we have wound care nurses as well. I would say it's a partnership, right? So we had a patient, and it was just this past week. They always like come in timely for your talks. Maybe you're just looking for them, I don't know. And my team member, I asked him again, okay, tell me about skin tears because it's getting real. And Joni told me, hey, I had this lady, and she knew there was not gum mastic adhesive being used on that site because she had placed that dressing and she was worried it was one of those thin skin, very superficial edema patients. And even though she was being as gentle as possible, and I know this girl, she was being gentle, that skin just tore. And so we immediately said, hey, wound care, come help us out, come see what we can do. Because the patient was like that all over. So where are you going to move your site that's not going to have that compromise? But I saw that site and I was like, oh my gosh. So I'm just on pins and needles. I don't know. There is HIPAA there, and I don't know if we still have that patient. But I am on pins and needles about eclampsia in that patient because it's a mess, and that happened without gum mastic adhesive. So I would say partner with your vascular access team. I do not have trouble getting those dressings off. If I have someone who has healthy young skin, a lot of times I don't even have to use alcohol to help take the dressing off. It sticks, but it's not impossible to get off after 7 days. If there's any question about the skin, I use alcohol to help detach it. I don't like using adhesive remover to do that unless I'm taking the line completely out, because that stuff is so hard to clean off the site so that my next dressing can stick. But I would definitely say you guys could partner and trial it, and I think you'd be surprised at the results.
Thanks. One of our attendees is saying that she saw that you have a CHG patch under the line. Do you see dislodgements with dressing changes when the patch sticks to the dressing and pulls the line out?
So that patch has a slit in it, and we try to line that slit up underneath the line, because yes, that is something that we fight. That is one of the two reasons that we don't put the gum mastic adhesive there. You don't need it that close to your site, for one thing. You want that CHG patch directly on the skin. And so what we do with that patch, and actually one of the biggest manufacturers of that patch actually changed what they say. They used to say to turn it so that seam, if you would, is not under the catheter. Lines were dislodging, and so the last time they came around to do teaching, which at our facility was a few years ago, they were talking about lining it up under the line. That doesn't always happen. Some of our providers turn it, and it can be it doesn't have anything to do with the gum mastic adhesive, though. It just has to do with how well that transparent dressing sticks to that antimicrobial patch. And so sometimes I've had to get down in there and just peel them apart. And if I can leave my securement device on while I'm doing it, I'll do that. Sometimes I'll put tape somewhere to hold the line just to try and keep myself from inadvertently pulling that line out. But it's a challenge for sure.
Any antimicrobial properties, or does gum mastic adhesive make any claims to that?
No. What it does is it helps the dressing stick. So you've got to have your chlorhexidine scrub or alternative product when there's an allergy to chlorhexidine on first before you put the adhesive on. Clean that side first.
Thanks. We've had a couple of questions about the use of gum mastic and tissue adhesive because of the combination of it helps secure the dressing and it helps with bleeding. Have you seen any help with bleeding from the gum mastic alone?
We have never used gum mastic adhesive on our bleeding site. So typically what we do when we've got a patient bleeding, we will go there and we will spend the time to hold the pressure that has not happened to try and achieve some hemostasis that way. I've spent up to half an hour before holding pressure on a site. And then we apply, we have a hemostatic powder that is, that's its whole purpose in life, is to seal off the site there. that we'll apply. Sometimes we've substituted in hemostatic gauze when we haven't had the powder readily available. I have actually done both before, but I've never thought about putting gum mastic on the bleeding site. So I haven't tried it, is the short answer.
Fair enough. What's your team look like, the staffing numbers?
So we have one full-time staff member dedicated to our large facility. We have on day shift, we have a 12-hour shift. We have a 12-hour shift that's called NOCO. That shift starts at North Colorado Medical Center, the large facility. That person's job there is to do the line rounds and the dressing care. Although depending on how busy it is, night shift may have already helped out with some of those, and the other person who's there dedicated to NCMC does. Around 10 o'clock, they go over to McKee Medical Center, and they respond to emergent lines only for Fort Collins. Now, if there's an emergent line at either of our smaller facilities, we just get creative, and between the two 12-hour day shift people, they get it done. On night shift, our 12-hour single night shift person stays at North Colorado Medical Center unless there is an emergent line need at McKee or Fort Collins. And an emergent line need is not just centrals. We do place central lines as well as PICC lines, centrally inserted central lines as well as PICC lines. But if we have a patient who they can't get access in and they don't really need a central line, but not having access all night is going to cause a bad patient outcome, we will go to those other facilities on night shift. So it's just a constant reprioritizing what you do. And it probably sounds horrible, but to be honest with you, because I'm not a night person, my favorite shift is that NOCO shift where I come in and I do all the site rounds. I like to get my eyes on those sites myself, and then I get to go over and do the same thing in a much smaller quantity at McKee and help them with their lines for the 8 hours that I'm assigned there.
Are you checking out all the lines in the facility, or just those outside of the ICU?
Oh no, we follow all central lines at all three facilities. Although for our small facility in Fort Collins, we only actually eyes on that site. When we go there, we usually have a conversation with the nurse every day if we have no other reason to go there, unless site care is due. And then yes, we drive the 9 miles between McKee and Fort Collins to do the site care on that line. We see all central lines. So if it's a PICC, if it's a tunneled dialysis catheter, if it's a non-tunneled dialysis catheter, if it's any kind of central, swan, sheath, anything like that, we will round on it every day while it's in that patient.
Do you use the gum mastic on all? Oh, sorry, Blake.
I was just going to say, along those lines, do you guys change them on a specific day of the week, or is it just whenever the insertion date is for the 7-day time frame?
It's 7 days and PRN. Now, of course, if there's gauze under there, that changes the dressing change time frame to 48 hours. Disruption, we change early, but yes, it's a 7-day regimen if everything is correct. If there's no antimicrobial disc and they're not allergic to chlorhexidine, then we change the dressing right then and get it in there. So if something's wrong with the dressing but it's intact, then we go ahead and take care of that issue.
That's perfect.
With your sutureless securement device, does the mastisol or gum mastic affect it or make the platform stick to the skin?
So I think the reason we often don't put gum mastic under that securement device is that securement device is extremely sticky. So underneath the securement device, it's not really needed. It's just overkill. So the particular one that we use is already super, super sticky. In fact, usually when I'm doing site care, I will get my old dressing off except for that device. And then I will use some alcohol over it to help loosen it. Even on people who have very young, healthy skin, just because I think that those securement devices stick a lot. So I don't put gum mastic underneath it on top of it unless it's a patient who just nothing sticks to. Even for hairy patients, I'd rather clip first. There are some patients that just have that, you'll put their line in and you'll wait for it to dry, and you'll wait for it to dry, and you'll wait for the chlorhexidine to dry, and you start to realize that through gloves they never feel dry. Then I might double up my adhesive under that securement device on those people.
Some interesting theories about like deactivating CHG sponges. Saline can do that in some instances. Have they made you aware of any issues with gum mastic as far as affecting the CHG sponge itself?
As far as I know, the only thing I can refer back to is that 2017 reference from Marcia Ryder and Colette Dully. You don't put gum mastic adhesive underneath that patch anyway, so I don't think that there's one way or the other there should be a conflict, because I wouldn't use it under there, just simply because trying to get that patch off that transparent dressing without pulling your line out, we don't need to add more sticky right there, if nothing else. But so it shouldn't be a problem, because they should rarely, if ever, partner. But I don't know that anyone's ever specifically studied it.
It's my understanding it doesn't belong at the insertion site.
That is my understanding as well, yes.
Perfect. Now, we do have a question about the change time. When you do the dressing change with a patient you have gum mastic down, does it take you longer to do a dressing change than it would prior to?
For my study, I added a minute because you have to have time to apply the gum mastic adhesive and let it dry. So I'm always very conservative, and I overestimate everything. So I gave an extra minute. Right now, because it's not in the kit, I have to open it and drop it in, and then I have to paint it on and wait for it. I was using skin prep on people prior to this, so for me, I don't think it takes me any longer, but I didn't always use skin prep. The skin prep that is in our central line dressing kit is atrocious. I know across our system, most people don't use it, whether they have gum mastic or not, just saying. So I don't think it takes you any longer. Maybe it takes me a few seconds longer. It doesn't take me any longer to remove it, because if their skin's fragile, I'm going to be careful whether I have gum mastic down or not. I mean, extra careful and go slow.
That's fair.
When you guys were looking at doing this study for the gum mastic adhesive, did you consider any other kind of tissue adhesives or bonding materials?
We did not. There really wasn't any reason for it. Reason why we did not. Gum mastic adhesive that I know of, and my knowledge is certainly not all-encompassing by any means, was to help hold that dressing down. Most of the adhesives that are being used on the site for bleeding and then under the catheter to hold it seemed more to me about that type of stabilization rather than stabilization of a transparent membrane. There may be other products on the market, and I certainly don't discourage anyone from looking at them, that are designed to do the same thing as gum mastic adhesive, but to hold that dressing down, it was something that was readily available to us. Again, like I said, already in our system, I saw the information that I wanted to see based on the studies, and so we moved forward with it. And with the cost savings and the effect that we've had, sometimes I'd rather chase after something that's broke than something that's fixed. So at this point, I feel like we've made improvement. So we probably wouldn't entertain a different product unless there was some very large reason to do so, when I'm unaware of any of that.
Yeah.
Fair enough. So looking at your opinion, and I know Shelley DeVries and I have talked about this a couple times, looking forward to what you have to say.
Okay.
When you're rounding on a patient and you see some of the edges are curled up a bit, let's see how far they say, the corners and corners of the dressing have become loose. and the rest of the dressing appears intact, or is it better to perform a complete dressing, or do you use some gum mastic to tack it down?
So I actually don't use gum mastic. If the corner is starting to curl, I really look at the whole site. And I look at the patient's skin condition. If I feel like that edge is curling because, I try to look at the skin. I look at the curling. Is this something that is going to continue, that I really feel is going to continue? Or if I put, and I usually just use paper, silicone, or even transport tape sometimes to tape that back down. But if it gets more than about 1/4 of an inch, we have this gauze. Our particular transparent membrane dressing has a gauze border, and I really like that too. And if that gauze border, if it's getting to halfway of that gauze border, I'm probably going to change it because I feel like it's going to continue. If it's just starting to curl, a lot of times I will tape it down. I have applied more gum mastic adhesive, because this high IJ where it just comes down from the face happens a lot. If their beard is growing out, it really happens. I have put a little gum mastic adhesive back up on that and added a little tape when my site is far enough away from it that I feel like, okay, I need to seal this better. This is going to happen almost immediately with the next dressing if I don't take care of this. So I guess it's case by case basis is what I'm saying.
Well, that's just an ugly line. That shouldn't happen.
I like the fact that you're pointing out like the high IJ insertion sites, and there are other speakers out there that talk about getting low along the collarbone and laying it a little bit more across that surface, making it flat. And I mean, certainly when we look at any kind of adhesive for the dressing, things like that, how much disruptions to dressings really change the outcomes, clinical outcomes for CLABSI, infection, just site care and maintenance, so.
The other day I had just a couple days ago, I had a 3-lumen dialysis catheter way up here, and those things are heavy. And the suture was either loose. I think the suture was loose because I couldn't put a securement device on it, and it was just pulling the dressing down. I changed this dressing, and of course, immediately at that area, mine is going to pull down. What are you going to do? You've got this huge weight, these curled over large dialysis lumens. And what I ended up doing was just really getting him as dry as, and he was sweaty and moist, as dry as I could back here. I put down, and there was very little hair there on him. I put down a piece of transport and I bridged other transport to just try and hold that thing up. I don't know how it works because I didn't work the next day, but sometimes you get creative with whatever because some of these sites are horrible. And I will tell you, all of our team does low approach IJs, and the difference between a low approach IJ dressing and a high neck dressing is huge as far as in terms of ability to stay intact and not have their hair in it, which hurts them terribly when you pull it off.
Especially in an HD catheter, that should be, they should get money taken out of their paycheck if they do that, they perform that.
Or
line.
They should have to have one too.
Seriously, that is a horrible thing to do to a human being, or more so even an animal, but nonetheless.
Fine.
So do you use gum mastic on everything, like A-lines, ports, the whole kit and caboodle?
It's an option to do so. We haven't. A lot of now say in general, we haven't. I do know that some of the team, when we put in an art line, will use gum mastic adhesive on the dressing. We use a lot of 8 and 10 centimeter accelerated Seldinger catheters, and I do not use gum mastic adhesive on those. Over here in the cephalic vein, a lot of times on the upper arm. You can. I mean, there's no reason not to, but we have not. So that might be something to consider, especially as we get further and further into looking at peripheral line associated bloodstream infection.
Hey,
It's coming. It's a real thing, right?
it's a real thing, Blake.
Yep. Well, I mean, you look at NHSN and the discussions around reportability for those kinds of infections, and if
It's
it isn't in
important.
the forefront of your mind, being proactive about that is something that we all
It's
have to
crazy, isn't it?
face eventually.
It's a circulatory system.
Yeah.
Why is it? Oh, yeah.
It isn't different. It isn't different, and there's no reason that you couldn't. As an overall mandate, since I supervise the team, I have not mandated that happen. I do feel, because I've removed plenty of dressings that other people have put on from cephalic midlines and art lines, that I know gum mastic was used, because I can tell when I'm taking it off.
Very good. Have you read the literature or know if gum mastic has any effect on the efficacy of CHG, the scrub itself?
Only that article that I referred to in my original lit search that was co-authored by Marcia Ryder. I am not aware of anything saying it doesn't. I would challenge anybody to say that it does based on our outcomes, because our outcomes are great. So I think if it was affecting our CHG, our CLABSI outcomes would be not so great.
Thanks.
Speaking of that, looking at gum mastic, as far as the dressing securement, just for the dressing itself, and just a comment from the audience here is that they had started implementing, some kind of tissue adhesive, and they found a very similar improvement in CLABSI rates. And you said that your team was looking to establish that. What are your thoughts on how that would be implemented for your organization?
If we looked at tissue adhesive, we would probably look at using it more of a bonding sort of at the site to help with bleeding sites, which actually in our team's place lines are virtually non-existent. But it's still good to have, because we take care of everybody's lines. And then maybe to help secure down the site. What I almost see of benefit, because we've got the gum mastic adhesive for the dressing, I would like to get into one of those, I'm just like a Securicath, or the intradermal securement device that you can deploy, because you can clean up under it and it can't dislodge, especially for our patients going home. We don't have that in Banner yet, and there's a cost associated with that that may make it a little difficult for me to get in, but I think we could have so many improvements of catheter dislodgement if we had something like that. If we had a lot of bleeding and we just don't, I think using a tissue adherence product is not a bad thing. There's an application for everything. I would like, in a perfect world, to have all the toys in all my toolbox, but I'm a little bit limited by purchasing agreements and those type of horrible things.
How do you feel about using Coban to help with edge securement on peeling up dressings?
Oh, did one of my team ask this question, because they all know that I hate Coban. I hate Coban so hard. Coban does not. Coban gets tighter. Coban does not let you see the site. Coban doesn't breathe. I hate Coban, so I would probably never do that. A stockingette over the site maybe to help, but yeah, no. Coban and I are not friends.
So just so we don't have any hate mail coming, Coban is great for the purpose it's intended, but I agree with you. I would not put it near a vascular access site.
And INS standards did come out this time, and you don't want anything that covers your site. And yes, when we use Coban appropriately, it in what it's intended for. It's a good product. So I guess my reaction, that stretchy stuff, I guess I should say instead of Coban.
I love the way you
Doesn't have
stated
any
it.
business over your vascular access site ever.
I 100% agree with you. I think you stated it well.
Okay. Hate is such a
Just
strong word.
picturing this the stockinette, with the floppy IJ hemodialysis catheter looking more like a scarf, the way you described it earlier.
Yeah, no, that wouldn't work.
So when we were looking at your team, how big is the team that you have, and is it 24-hour coverage?
We are 24-hour coverage. So there's me, and I work 5 shifts a pay period, which is 2 weeks, and 1 to 2 of those shifts are managerial. Otherwise, I'm doing what everybody else does. There's 2 other people that officially live in North Colorado Medical Center's cost center, although we float back and forth all the time. Let's see, there's 7 of us that are dedicated, and then the rest are second position, or I have a banner staffer. And then in the bottom right-hand corner is Jamie. She is a NICU vascular access nurse specifically just for NICU, but she is part of our team now. The lady right above her is Victoria. She joined our team. She was a NICU vascular access nurse, if you will, prior to joining our team. So we've pulled in the NICU. And so even though all Jamie in particular does is babies right now, it's all part of the same service. So full-time employees, I don't know, I think we have like 7 FTEs that are split up into part-time people when you talk about it.
Okay. Do you have specifically designated PIC versus central line like IJ inserters on your team, or is everyone capable of doing all the devices all the time?
So we still have just a few people that haven't checked off on centrally inserted central lines. I have thought at length about our 1 banner staffing person who is not a second position. He works 1 to 2 shifts a month, and if she's listening, I haven't told her this yet. So Emily, you're not going to have to do central lines. If you're listening, she listens a lot. She does almost every education opportunity, so I wouldn't be surprised, because I don't think that's appropriate or fair to her. But we're in the process still of signing off a few people for central lines. Some of them are newer to the team than others. Our night shift program is not extremely old yet, so good thing to get practice with the ultrasound before you start poking people in the neck. But no, we can all do everything with the exception of our 1 staffer person.
Yep.
Do you place IOs?
We can. We have not had to, but we can. We have a drill on the cart. We're all checked off. And yes, if I had to drill somebody, I would drill somebody.
Have you?
Have I?
You placed one? Yes.
In me, just in training and in refresher courses, because I haven't needed to.
Okay.
I have not needed to. And honestly, to be fair, the only time I would do it, it would be if I was in maybe the small facility, none of the nurses working there had ever done it, because I am trained and I keep the training up. And if it was necessary at that point, I have been able to obtain alternative venous access without going there. So I haven't had to, but I am trained. I do the necessary annual refresher, and we have our drill and our needles available if we need them.
Well, good girl. I love an IO in the morning. Well,
What's the composition of your team look like? Is it mostly RNs, or do you have respiratory therapists or radiology technologists that,
We are a blended team of registered respiratory therapists and registered nurses. So we have both of those licenses as vascular access specialists on our team.
It's awesome.
Do you do a 1 or 2 person insertion? Do you have a second set of eyes?
We have to do a 1 person insertion because that's where we're at staffing wise. Now, I have been poking at my administration for some time now regarding that. But we do. And now, remember, I don't know if somebody did ask. So for 4 hours in the morning while we're doing line rounds, the NOCO staff person and the dedicated NCMC person is at that facility. And sometimes we do lines together when we're training someone. Obviously, there's 2 of us there that either know or are learning to know what we're supposed to do. But unfortunately, no, we do not consistently have an observer. And it is not for lack of trying to get one, I can assure you.
That's awesome.
You know, it's a struggle. There's so many things that I think if you could ask anybody that's listening still, say, okay, if you had Oprah's top 10 list, what would you pick? I think we could probably just roll it off our tongues. I want this and I want that and I want this for every one of my patients. And
Yeah.
we don't have that luxury most of the time. But always
no.
It's winning the lotto of vascular access. What do you get?
I would actually, I have thought if I had the ability to staff with a second person at every facility on all shift, what license or training that individual had, and should the opportunity come up, I would have to look more into it. But I've thought about a lot of things. I've thought about having a second person who has an EMT background. Don't get scared by that. 2 of my nurses are ED nurses, and they do a great job. They're taking their knowledge back to the ED too, which is really good. But I think that I wanted them to be able to do peripheral IVs with ultrasound, because I'm very good at freehanding, is what I call it, when you don't use anything, and a needle into the vein. But I still only get to do it 50% of the time on the patients I see, because my patients are divas. They're not the easy ones. They don't call me for the easy ones. We're not an IV team. And I thought, okay, if we have a second person, who can we build on? What certification can we build on that could be cost effective in this world of watching costs? But in the state of Colorado, EMTs, even EMT IVs or an EMT advanced, may not use ultrasound to place IVs. So it just gets tricky. And if I ever have the option of having that second person on, I will probably, as a manager, look at who I could work with that would do a great job with the proper training and be cost effective.
Yeah.
And be able to do what I need them to do.
Very good. We had a couple, one more question for you, and I'm going to try to clarify it and then have you answer it. Somewhere in the discussion, you mentioned needing antimicrobial at the edge of a dressing, possibly. Why would that be?
Well, say that again.
Why would we need antimicrobial protection, I'm assuming, at the edge of the dressing?
I think I know where this is coming from. So it's kind of like, does this have an antimicrobial property? And,
oh, okay. It backed up that question.
And really more of a statement is, why would you need it at the border of the dressing when you need it at the insertion site and around?
Right.
Yeah.
So your CHG is your antimicrobial. Your CHG scrub that you do, or your alternative if they're CHG sensitive and can't have CHG. Your CHG scrub is your disinfectant. The gum mastic adhesive is to keep the dressing on. That is what it's for. And so it's hard without a dressing right here to show you, but you put the gum mastic adhesive around like the last inch border that the dressing then goes over when it's dry, because it's to hold the dressing down. You put it over, hopefully you've used CHG to scrub all the way from edge to edge and then some of where you imagine you're going to put that dressing down, so that when you put that dressing down with or without gum mastic adhesive, you're covering something that's been scrubbed and allowed to dry before you set the dressing down. But you paint the gum mastic on, let it dry, and then you set the dressing over it too. But its purpose is to keep your dressing sticking. If it does have antimicrobial properties, I'm unaware of that. The CHG that I cleaned with first and allowed to dry is how I achieved my as aseptic site as I can get.
Perfect.
Yeah. It's that persistence of the chlorhexidine gluconate that really keeps it sterile through the 7-day cycle, and really keeping it intact is where the biggest bang for the buck in gum mastic kind of lives. So
Absolutely. So we had a couple comments as we close up, and Blake, I'll have you close us out. Sadly, our facility dissolved our night VAT team at 2 large facilities. She loved her job, and some nights she placed 30 PIVs, 5 to 6 midlines, and stopped our observation of lines. And now their answer is to avoid lines as much as possible. So it's a sad thing. And the other is one of our folks out here, Dana, wanted to thank you specifically for, she appreciates your no bias presentation style, and you are very good at addressing issues without seeming to be pushy or particular, and staying on focus on what's best for the patient. So I wanted to give you that public shout out.
Well, thank you. That's where I come from. The bottom line is what's best for the patient, and we don't settle for anything less than that whenever humanly possible.
Perfect. And someone from Mastic actually shouted out for us that CHG and Mastic is quite compatible, as we all assumed. But thank you so much, Jessica, for that clarification. Blake, you want to close us out?
I do. All right, let me see if I can get this switched back to my PowerPoint for the last